morning everyone. This is the last session of this first midterm conference, and I would be talking on Phaco in pre-existing posterior capsule rupture. So introduction is that pre-existing PC defect is always challenging in managing these cases because of high chance of the nucleus drop and vitreous collapse, and the choices of intraocular lenses are also very limited. There are so many causes of pre-existing PCR. We all know that posterior polar cataract can have, but I won't discuss posterior polar cataract here. I would basically focus on trauma, that is more in open globe injury, pars plana vitrectomy procedure, post-intravitreal injection, and some of the congenital cataract. This is one of the slide pictures of post-traumatic cataract. You can see there is just big tear in the posterior capsule in this post-traumatic eye. This is posterior lenticonus, known to have PCR during the surgery. This is a case of post-intravitreal injection with PC defect. So these type of cataract generally have a rapid onset of progression, and there can be some history of trauma, intravitreal injection, or history of undergoing pars plana vitrectomy. And in the slit lamp examination, if the cataract is not total or not matured, you can see the posterior capsule defect. And there are some other clinical signs also, like pistil signs, white demarcation line, or sometimes white crystalline particles floating in the vitreous. So how to confirm? Clinically you can see on the slit lamp, and you can sometimes just for demonstration purpose you can do an entry segment OCT, simple imaging, and if the cataract is total or dense, you can take the help of the UBM or routine B scan. You can see here there is PC defect in this UBM. Just few things about post-intravitreal anti-VEGF injections induced traumatic cataract, because nowadays anti-VEGF injections have become very common, and nowadays not even those who are not giving any intravitreal antibiotic for endop are also jumping into giving this anti-VEGF injection. So there are chances that that can injure the posterior capsule, because they may not be well trained for that. So if there is touch to the posterior capsule, there can be the PCR can remain sealed, so sometimes there may not be progression of cataract, but if there is bigger touch, it can progress very fast, like in Nozudex injections. So how to approach these patients of any PC defect already having pre-existing PC defect? You have to properly counsel the patient, explaining everything about the risk and challenges during the surgery, and the chances of that you may not implant the lens which the patient is opting for. There are increased risk of nucleus drop, and all these patients should be done preferably under peribulbar anesthesia and treat it as posterior polar cataract. So for that you have to take you have to keep your parameter as low as possible and as gentle as possible. There should not be any hydro dissection, no nucleus rotation, and keep always VR backup ready, and three-piece lenses as backup also. This is just a clinical picture of the post-Accentrix patient. You can see big tear here, big tear here. The entry segment OCT is showing this. This is the simple imaging. Coming to the just small video of this. There is no hydro dissection, just hydro delineation of this softer cataract, and I just help of the manual irrigation aspiration, and everything was going very well, but here suddenly there is vitreous collapsing to the PC defect. So I had to stop, but before taking out the irrigation, I injected viscoelastic to the cataract, and now going to the pars plana, taking the pars plana route to do the intervention. Going to the posterior part actually clears each and every bit of vitreous from the anterior chamber, and doesn't allow more vitreous to come into the anterior chamber. And it's also very helpful to take out all the cortex and put in the three-piece lenses in the surface, and increase the capture, optic capture with the entry capsule here. And we'll use translunon at the end just to see that there is no vitreous stent there in the anterior chamber. This is a case of post-Nozudex injection. This you can see big tear there. I won't want to go into the detail in the surgery because of the paucity of time. Coming to this post-traumatic cataract, the picture which I just shown here, shown in the previous slide. Small video of clip of that. After doing the anterior capsulotomy, I am just using the irrigation going behind 2.5 millimeter behind and doing the same thing, clearing all the requests and taking out the remaining vortex. And it's always mandatory to put 3 lenses in such situation if there is no enough capsular bag to support the single-piece lenses. The same dictum or same principle one has to follow, that use clamp minimum and so that we never miss any mistake during the see, this is the clinical pre-op and this is the post-op picture. This is another young patient who suffered an injury, and actually there was significant amount of astigmatism, so I thought to put toric lens here. Again, it was possible to take out the cataract part with the manual IO, and you can see the big defect here. And the only principle is that never allow the chamber to fluctuate too much, always keep the chamber tight. So whenever you take out the irrigation, before that you have to inject visco on the tripod so that chamber remains on, and that is the principle one has to follow so that you can have intact alloyed face without having any problem. So this toric lens has been planted in the bag. There was enough support, so it was possible to implant the lens in the bag itself. This is the pre-op picture and this is the post-op picture. So just to summarize, pre-existing PC tear can occur in certain conditions, and there is nowadays there is a rise in incidence of traumatic cataract due to intravitreal anti-VEGF injections right and left, and that these patients needs careful pre-op evaluation and meticulous and patient surgical approach is needed, and always treat this patient as a case of posterior polar cataract with PC defect. Thank you very much.
Thanks a lot, Dr. Subhash. Wonderful presentation. Any queries, any questions from the house?
Sir, you use actually scaffold only when there is chances of nucleus drop. But in these cases, since there was not a very hard nucleus, so it's not needed. But otherwise, one can always use that. It's a very good option.
So there are few comments. Subhash has been so comprehensive. There's nothing much to add. So one thing I would like to add is pre-op evaluation. You know, a 20 megahertz ultrasound probe functions better than a taking 10 megahertz probe. And earlier on, we used to borrow this thing from the gynecologists. They use a 20 megahertz probe. Number one. Second thing was the surgeon also. It helps if the surgeon is well conversant with SICs.
Yeah.
Because at certain points when you know that the nucleus is about to go down and you don't want to have a two-stage surgery, if you can do an SICS, then you can finish off the surgery in the same sitting. The third point is now you demonstrated the 3-piece IOL injection pretty well. Now what has happened is initially you are getting it from Johnson & Johnson sensor Air 40. This is not available in many powers, so we have to use other Alcon lenses. So
now the Oro, Oro is coming out.
Yeah, Oro requires a much, I think, bigger incision.
But sir, I'm using the B cartridge of the Alcon for that, so it's going to
B cartridge requires, if you require 2.8 is C cartridge.
No,
B
sir.
cartridge requires more than
no, sir.
C,
I'm using C cartridge.
C cartridge. So
B requires 3.2.
Yeah. B requires a larger cartridge. And many of these cases actually, for example, the toric pattern that you showed, we don't overhide those cases because we do not want the lens to rotate. So maybe just put a suture and remove the suture after a week instead of over-inflating the capsular bag may help in those situations. Otherwise, it's a lovely talk. And over to the next speaker.
Thank you, sir.
Dr. Deva Prasad Gopal is here. Dr. Anil Kumar Singh.
This is given for CNBM, the wet AMD. It won't, it is a treatment for that.